Hey folks, I'm going to get started. Looks like we're a little slow gathering this morning, but hopefully by the time we get through the introductions and announcements, more people will be able to join us. It looks like, thanks, Rick, I have control of the slides. Again, the usual reminders, please avoid discussion of private health information when you discuss your cases. These are the usual reminders about assistance and a bit more about cardio. And this is our entire team. And I'll be presenting today and facilitating as usual. Interesting case. I think Mary Lee and Karen are well qualified to comment on this one in particular, including the issue of trust, I think, and trust, not just physician-patient trust, but also pharmacists as well. Pharmacists are among the most trusted of all professionals. And Sarah will be presenting the case this morning. So our usual disclosure statements, there's nothing new. I don't have anything to disclose. We're going to talk about empowerment. And just to put this in context, I was in clinic yesterday, had a lot of patients to see. And my clinic I just can't spend the whole day there. I have places to go in the afternoon. So you're always stressed about trying to get out on time. The patients don't care. They don't understand that you have many other jobs to do. And I had a med student with me, and she was very good, but she was very thorough and very slow. And my inbox was filling up, and then nurses and everybody was asking me questions every 2 or 3 minutes, completely unrelated to patient care at times. Plus, I have a study section today, and I couldn't get into the system to upload my scores, and that was a source of stress. So the IT people from the NIH were in touch about every 5 minutes. So it was a brutal, absolutely horrible day in that sense. And I thought on top of that, I'm expected to respond to quality initiatives, et cetera, from the system to try to improve the quality of care. So the Epic best practice alerts was firing. You have 10 practice gaps on this particular patient, and some of them are not legitimate. So I say all that because I think there's got to be a different way of doing things. And this is one paradigm or one strategy that we're going to talk about today. So I want you to define patient empowerment, describe empowering patients to seek high quality care for the prevention of cardiovascular disease, describe an approach to patient empowerment within a busy primary care practice. Empower is a word we throw around a lot here at UH, and CASE in particular. I'm a PI of a study called Empower. We also have Empower BP. Kelsey is a PI of a study on telehealth training, which is empowering patients for telehealth. So a number of different intersections here, but the basic concept is this. So here's the scenario. So patients with diabetes and established cardiovascular disease, only about 57.9% have controlled blood pressure. We wish it was higher. Why? Do we not know what to do? Do we not have enough information about how to do this? And have they not arrived in our mail and in our clinical decision support systems and through ECHO? Is that the problem, really? Of course it's not. Do we lack quality measures and standards and associated provider incentives? Absolutely not. We have those in place in my system and in all of your systems. So, one of the most common quality measures is the proportion of your patients that have a hemoglobin A1C, let's say below 8, and how many have a blood pressure at 140/90 or lower. And those are not the actual guideline-based thresholds, but they're a starting point. Is it a lack of innovative models of care? I don't think so. We have complex primary care. We have distributing tasks and responsibilities among team members. We have the chronic care model, which I'll talk about briefly in a moment. So there's no lack of tools, programs, and models of care, many of which are linked to financial incentives for physicians for their effective use, available to improve quality, and lack of cannot explain widespread quality problems. That looks like a quote. I actually wrote that somewhere. I don't remember, but I'll put it in quotes for now. So here are some of the explanations. So one common term that's been thrown around is clinical inertia. And that's the failure to establish appropriate targets and escalate treatment to achieve goals. It's a potential cause of care gaps when 3 conditions are met. But what does clinical inertia mean? So I gave this example last year. If Austin and I are in practice and he's on vacation and I'm seeing one of his hypertensive patients and the pressure is high and I'm thinking about adding spironolactone, I say, I don't think I want to do that. You can wait till he comes back. He comes back, we're not in the office together. He sees the same patient. He says, well, Dr. Rao didn't want to do it. He must have had some thought about this that he didn't put in the record. So I'm going to hold off and we'll check it again next month. Comes back next month and sees somebody else in the office and says, yeah, I think Dr. Friedrichson's probably going to think about intensifying treatment at some point. And it goes on and on and on. And we don't do it because sometimes the easiest approach is to defer care in that way. But you have to have three conditions, because it's a term that's thrown around a lot. And I think it's rather unfair for those of us in primary care. There has to be an implicit or explicit guideline. There can't be uncertainty about what to do. And you have to believe in the guideline and its application to your patient in particular. So I've been on a lot of guideline committees, and sometimes they're just not realistic. I mean, a lot of those folks are not in practice and they don't understand the realities of it. The physician has to have the resources to apply the guideline, including time. I'm going to intensify your blood pressure treatment. Let's talk about this and let's go through a shared decision-making approach on how best to do it. What medications have you tried before? What experiences did you have with those medications? What can you do in terms of lifestyle, et cetera? That takes time. If all those three conditions are met, but the physician doesn't follow the guideline, clinical inertia is said to be the cause. Now, that's one explanation for why we are not able to control cardiovascular risk. The next one is poor engagement with care. Now, patient factors play an enormous role. Patients can be very passive. They may not be engaged in care. In family medicine, in our clinic, about 30 to 40% of patients don't show up for their appointments. In pediatric primary care, it's more than half in some settings. And that's poor engagement. You cannot control someone's cardiovascular risk if they're not there, right? It's as simple as anything. A lot of patients have limited interest in self-management, including lifestyle modification. So people have busy lives. They have a lot of other things. Now you're asking me to manage my own diabetes or high blood pressure as well. That's good self-management is very common among people that are more highly educated, more motivated, alarmed by, some of their cardiovascular risks, but that's not for everyone. There's also system factors, of course, time and productivity pressures. And our primary care structure is not well designed for managing chronic illnesses, especially things like type 2 diabetes, which is very complex. So these are some of the factors that are involved. We have had solutions. The chronic care model, this is from the early 1990s. Ned Wagner developed it. And what it says is that we can manage chronic illness and other illnesses in primary care if we have an interactive system that involves the community, the health system, that provides self-management support, delivery system design, decision support, clinical information systems, and that leads to productive interactions. Fact is, we have many of these already. We obviously all have clinical information systems and decision support. We have lots of support for self-management, et cetera. And we have barely moved the needle on improving quality of care. In fact, in some cases, things have gotten worse. So even though it is a useful paradigm for organizing our care in a way that delivers management of chronic illness in an efficient way, it's not necessarily the right solution. So we have to continue to look. So here are some other things. These are concepts that I think are really important that are related to empowerment. So shared decision-making, this term is thrown around a lot. So an approach where clinicians and patients share the best available evidence when faced with the task of making decisions, and where patients are supported to consider options to achieve informed preferences. It's I think a little vague. So I can give you an example. Yesterday, I was seeing a lady who has carpal tunnel syndrome, and I think she has carpal tunnel syndrome. And I said, well, we have a few options. We can do nerve conduction studies. That's kind of painful, and it'll be a while. Or we can treat you with some braces, or you come back and I can inject your carpal tunnel with steroid, or we can entertain other options in terms of medication management. There was a number of options here. Let's look at these possibilities and the advantages and disadvantages of each. It can be effective with an engaged patient. In this particular case, she kind of deferred to me and said, "No, I'm going to try the naproxen for a couple of weeks, and I'll come back and let you know how things go." And it seemed like the easiest thing for her. Patient activation is different. So it's the patient's willingness and ability to take independent action to manage their health and overall care. More activated patients have better outcomes. More activated patients with diabetes are more likely to perform foot checks, eye exams, exercise regularly, compared to less activated patients. So this is an entire strategy. And one of my former mentees, Jennifer Bello, who's now at St. Louis University in Missouri, but was at the University of Chicago with me, did her K award is all about reproductive health activation. Ask your doctor about your contraceptive options. Okay, that's the essence of what she's doing, and she's had significant success. And I've said this many times in this ECHO program and in others. One of the most effective interventions I've ever had in the pediatric hypertension world is ask your doctor about your child's blood pressure. Just a poster. Okay. More effective than clinical decision support, distributing guidelines, echo curricula, etc. Mom and child walk into the office and say, "Hey, I saw that sign out there. How's his blood pressure?" And gosh, boy, that you better have an answer for that, right? So that's the sort of thing that is helpful in overcoming some of these other factors. Empowerment is a little bit different. It means to promote autonomous self-regulation so that the individual's potential for health and wellness is maximized. So what is autonomous self-regulation? It means that they take charge of their own health and their own well-being in particular in a way that is important to them. It doesn't mean the patient is there printing out internet pages and asking you questions and telling you what they think they have. That's not necessarily empowerment, but they take charge of things. So Jim and I see patients in Fitter Me, and in our obesity treatment program, we give them very specific goals. And there are different kinds of responses to it. Some people are hesitant. "I don't know if I can do it." He goes, "No, I'm going to take," and there's others who say, "I'm going to take charge of this. I'm going to be responsible for this. And I'm going to show you that I can achieve a healthier weight." So it really is more of an internal sentiment rather than an external behavior. So you empower patients by giving them that ability to autonomously self-regulate. You don't empower patients by bombarding them with information necessarily. And the patient doesn't necessarily have an attitude that puts you on edge at all. That's not what empowerment is. So we are behind the curve when it comes to empowerment. This is the European Charter on Patient Empowerment from the European Patients Forum. Some of these statements, I think, are things we would all agree with, and not necessarily related to empowerment, but they are designed to promote that autonomous self-regulation. So I'm more than my health condition. I am empowered to the extent I wish to be. Maybe I don't want to make decisions about my chemotherapy for cancer. That's too complicated. But I do want to be able to decide where I receive care and when I receive care, and what my wishes are for care in general. I'm an equal partner. I have the information I need in an easily understandable format. My health professionals and our health system actively promote health literacy. I have the ongoing support I need to manage my own care. My experience is a vital measure of healthcare quality, not just the hemoglobin A1C, not just the blood pressure, but did I have a suitable experience? So in a number of the research projects we have, that's a critical outcome. So I can participate in evaluating co-designing healthcare services. Through patient organizations, my voice becomes larger. Several of us are involved in the Society to Improve Diagnosis in Medicine, which has a very, very large patient empowerment panel. Equity and empowerment go hand in hand. I want a fair deal for all patients. And that's important. And that's where we're going to land today. In other words, some patients are less empowered than others. The primary driver of empowerment seems to be education, okay? Educational level, income, socioeconomic status. And I sense this every day. The majority of my patients are poor, older African Americans who live in the vicinity of Cleveland Medical Center. But about 20% of them are, professors at Case Western or other physicians. And my goodness, there's a huge difference in the extent to which they are empowered to manage their health. And we want everybody to achieve a high level of empowerment. So who is empowered and who isn't? These are not gigantic differences. From a racial standpoint, I don't think there are as much as you extent. Actually, most Black adults give positive ratings to the healthcare they receive, which doesn't mean that they're empowered necessarily. No difference, I think, between men and women. The big difference, of course, is income-based. And 40% of Black adults say they had to speak up to get proper care. However, these differences are not, it's actually higher, for example, among the overall population. Not huge differences. So keep this in mind, especially in this echo. We have a lot of folks, patients that we discuss from rural areas. One of the common things is most of them are economically challenged. Most of them have either not finished high school or haven't gone past that. And whenever we do discuss patients that are much more highly educated, they're asking questions, they're doing things that are empowering to them. And there are fundamental psychological reasons for that. It's not just that they're higher functioning overall. It's that if you are of higher income and higher socioeconomic status, you have more to protect, okay? In terms of your family, in terms of your house, in terms of your reputation, et cetera. And because you have more to protect, you take more responsibility for your health. I don't know if we had this session, I think, with Adam Przinski or Jackson, right? If everybody was well-to-do, we would solve the problem of health disparities, pretty much. But we can't do much about that. So we had some efforts to develop approaches to empowerment. And this is one way to approach the issue of type 2 diabetes. And so you are trying to activate a patient. You're trying to give them an incentive to be more engaged in their care. And you can do something like distribute this checklist in advance. Some people will throw it in the garbage. Some people will not fill it out. Some people will fill it out and not raise any of these issues with their physician in deference to them. But a significant proportion will feel empowered. And if enough of those patients feel empowered, they are actually prioritizing what's important to them. The corollary is, isn't this demoralizing for the healthcare provider to have someone here and say, hey, you haven't discussed my blood pressure? And actually, not really. As long as the interactions are respectful, the patient is identifying what's important to them. And if you've ever encountered an empowered patient, the discussions are a lot more meaningful. Here's what an additional thing you can do to help with your cholesterol. And that becomes a more rewarding encounter. And that's what it's been shown. So that encounters with patients who are more activated, more empowered, are actually more rewarding than those who are less so. So some of the questions we put in this that was developed over time is, have you discussed improving control, adding medications, your blood pressure, your cholesterol, exercise, quitting smoking if you smoke, checking, has your doctor checked your urine, referred you to the eye doctor, offered you a flu shot? These last two, I think, were added by Kurt Stange. Does your doctor know who the most important people in your life are? I think that's really meaningful, right? Especially when it comes to managing of chronic disease. And we don't know. In this ECHO series, we discuss all the time what social supports people have. But this is a critically important question. In caring for does your doctor consider all the factors that affect your health is another critically important question. Maybe there's something else. Maybe it's poverty, maybe it's depression, maybe it's being in an abusive relationship that affects how you manage your diabetes. So just one way to empower, and the scenario would be you actually ask those patients to fill something like that out You don't give it to the doctor. You just walk in and they can raise some of those issues or they don't have to. So what can we do short of something that's so formal to empower our patients? Well, here's a few ways to phrase questions that are important. The National Academies of Medicine are very interested in empowerment. And I was one of their committees related to obesity, but it's pretty applicable across the board. So don't ask your patients at the end of an encounter, do you have any questions? Any questions? Or, I mean, or the abbreviated form. I think our younger, generation Y, Z healthcare providers are better at this. But people that are older would say, any questions? And that's actually kind of an intimidating way to ask that, isn't it? It's like, no, I'm good. That's not how you do it. He goes, what questions do you have about your visit today? And you pause and you wait. Wait 30 seconds if you have to. Let them have a chance to think about it. And they may not come up with anything, but even if they come up with nothing, that means they're reviewing the encounter in their head and they're trying to think of, well, actually, you've answered most of my questions, right? That is an empowering way to talk to your patients. Now, the patients that are already empowered are going to ask questions. They're going to be satisfied. They may even take notes, right? They may text their relative or their spouse or whoever it is. That's different. But we're talking about people that are generally quiet, don't feel empowered, and you're asking, do you have any questions? And when I have done this, the questions are often things that I thought we had already covered, right? Oh, I didn't know I was going to pick up the prescription after this. Yes, yeah. So make sure that you phrase it that way. If you say any questions, then you're not going to get much out of it. This is with respect to diabetes, but of course it could be about anything. What do you believe you need to better manage your diabetes? Okay. Here's what I need you to do. Okay. I need you to show up to the eye doctor's appointment. So, you missed the last one. That's not the way to interact with patients. What do you believe you need? And the responses you will get will be very interesting. They're not going to say, I need a new SGLT2 inhibitor. They might say, I really wish my husband was more engaged in helping me out, but he's got his own chronic illnesses and he's very sick. And what might help me is if I had more help to help him. And I was like, wow, I didn't know that was going on in your life. So that's a very empowering question. How can I help you achieve your goals? Now, this assumes you've helped to define those goals. Is really important. So you can have a shared decision-making discussion is like, I really need your hemoglobin A1C to come down. And, we've talked about putting some of these new medications on board and some lifestyle changes you need to make, period. Do you agree that those are reasonable goals? And most of the time, hopefully they'll say yes. He goes, okay, what do you think I can do now to help you beyond what I've done already to help you achieve those goals? Not to get there, you need to take this medication every single day. You need to walk, you need to exercise, you need to show up for your appointments, etc. Let them explore that. And then you could even come back and say, well, okay, that's a good idea. Here's what I think as well that would help you. Okay, let's stop there and see if there are any questions before we go on.
Hi, Dr. Rao. Good morning.
Good night.
So I'm just kind of curious because I know you presented different questionnaires and whatnot, but what metrics are you using to measure quality improvement?
Quality improvement for chronic disease or empowerment itself?
I thought you had mentioned quality improvement, but for the you mentioned that earlier, right?
Yeah. Mm-hmm.
Yeah, for quality improvement.
Yeah, I mean, there's a huge number of quality measures, Danette. And so I'm on the National Quality Forum's Core Quality Measures Committee that has about 108 measures that apply to chronic diseases in primary care. For example, hemoglobin A1C below a certain level, proportion that have their urinalysis done every year, et cetera, et cetera, et cetera. There is a paradigm shift in it. So we have a quality of primary care measure as well. that Dr. Stange and Rebecca Etz developed, and that's been adopted by the National Quality Forum. So, for example, it would be things like, my doctor and I have been through a lot together, yes or no, and you get a score based on it. It's been validated, it's been used. It was a real slog to get it through because it was so unusual, right, to do that. I think that the traditional quality measures are helpful, but they can be highly demotivating as well. If it's like, you are not, I mean, we all have somebody from our system, I'm sure, that says you're not meeting some target or goal. I certainly have that, and I have to actually deliver that information to people in my own department as well. And that can be highly demotivating. If we actually start to look at things that may have a longer term impact, such as the degree to which your patients feel empowered, the degree to which they feel engaged in care, those are quality measures that are important as well. I mean, all our patients are going to have different hemoglobin A1Cs. It's not necessarily clinical inertia. It's not necessarily that we're not good fit providers, but it may be a lack of empowerment as a strategy too. I hope that.
Yeah, that's helpful, because I think that's kind of, I mean, if we kind of like look at that even like as a team, then that can kind of shift everyone's focus, and we can all kind of be on the same page and how we're helping patients and whatnot.
Yeah,
So
that's a fantastic idea. So it's not just the physician-patient encounter, but imagine on your way out, your MA or your nurse says something like, "Oh, it was great seeing you again. Did you have any questions about your visit today? Or is there something left?" And that would be very, very empowering, I think, as sort of a team-based approach. Paul, I think you and Danette kind of were about to speak at the same time. Go ahead.
No, as always, I'm just fascinated, Dr. Rao. Your resourcefulness just absolutely amazes me. I'm tempted to steer the conversation in a different direction, but I don't think you want to do that. The system, we have a system, healthcare system in this country. We go back to the 30s and the 40s before we had health insurance. You guys probably know, prior to World War II, the world health insurance was basically non-existent. There were price and wage freezes put in place to deal with the war and the Depression. And the only way you could hire good people was to offer benefits. And the benefit they started offering was health insurance. And that's where it started. And there was a shift of paradigm of responsibility. And that's the line that, I don't know if you want to cross that line or not, Dr. Rao. The shift to responsibility, I say this with all the respect in the world. As recipients of the healthcare system, individuals, patients, have been deprived of a sense of responsibility of being involved in their healthcare and being involved in making decisions. And I don't know what the answer to that is. I say that because it needs to be said, but I try to say it without pointing a finger, because I'm sure I'm as guilty as the next person of feeling that way. But the interactions that I've had with patients and clients over the years is, it's not my responsibility, it's somebody else's responsibility. It's your responsibility. And they believe that. That's the part that I have come to understand. They honestly believe that, bless their hearts. So I don't know how to deal with that. And like I said, I'm not sure that you wanted to steer the conversation in that direction, but those are the thoughts that I see swirling around in my mind as part of the answer to what we're dealing with.
Yeah, those are great thoughts, Paul. And I think that I think the socioeconomic factor is absolutely gigantic in terms of how people interact with us. I have a patient, he's a professor of engineering, he's originally from Nigeria, and one of the things I told him to do 6 months ago was to exercise less, because he was getting numbness in his arms, and he was obsessed with controlling all of his health. I mean, he looks amazing. He's probably early 70s, and he looks much younger than that. And he's incredibly empowered, right? If everybody was like that, we would have very few problems. So the people that need empowerment the most in our society are the ones who are suffering most from chronic disease. It's like, the Medicaid recipients are the heaviest smokers, spending the most money. They're the best customers, right? Junk food customers are fast food is expensive, and it's a huge business. And the customers are the ones that are suffering most from chronic disease. So how do we change the paradigm? So how do we get patients empowered? I think is with the kinds of tools that I've described. I don't think we can make everybody very health literate or give them great jobs or have something to protect. And, you know, oh, I drive a nice car, so I want to be healthy. That's not going to happen. We don't have that within our scope, but we can give them brief tools. And a lot of them will not respond to that. And my colleague Jen's work shows in terms of reproductive health outcomes. And this is mostly with Latinx women of lower socioeconomic status in Chicago, that some of them, you know, are really feel empowered by it. But a lot of them would say, you know, this isn't, I don't want to be empowered. You know, if I get pregnant, it's just going to happen and I'll cope with it no matter what she does. So we're going to deal with that phenomenon as well. But I appreciate your comments about patients' responsibility and where we've moved in. All right, I think that's all we have. Before turning things back to Andy, Andy, I'm assuming we always need more cases, but I'm going to implore you, this is a great case. Sarah, thank you for presenting this morning, but we could always use additional ones, especially as we get into the heart of this ECHO series. I will not be here next week. I'm going to be trying to empower parents to handle their child's food allergies in Washington, D.C. So I'll be there for a couple of days on Thursday and Friday. But back to and Jim has kindly agreed to fill in for me for next week. So Andy, back to you for a minute.
Just another reminder that you can access all past and present ECHO recordings on our website. Next slide. A post-clinic survey was emailed to you. Please complete that by tomorrow at 5 p.m. As Goutham was saying, we will always take extra cases. So if you haven't already, please submit those. And a schedule was sent out to you. If the date doesn't work for you that I scheduled, please let me know so we can change that beforehand. Thanks.
All right. Thank you, everyone. Have a wonderful rest of the week. And I'll see you in a couple of weeks. Take care.